Hello and welcome back. This is part 2 of the chapter on blood and clotting. In part 1, we covered the different kinds of anemias, and in part 2, we're going to do the clotting disorders. I was a little long-winded in part 1, so I'm going to do my best to stay more efficient in this second half. So we're going to be doing hemostasis, meaning blood clotting. It's essential for survival after there's traumatic vessel injury. This helps us to, stop leaking out. With a very broad strokes, we're going to define this. The process, we have platelets that initiate clotting, and then they provide a scaffold for fibrin deposition. Then on top of the platelets being in place, then there are these coagulation factors that finalize the clot formation. This fibrin is the grand finale of the coagulation cascade. So that stabilizes the clot. And then if any of these parts is not working right, working too well, we get hypercoagulable states. We're making too many clots and occluding blood flow. That's a problem. And the opposite is also a problem. If we're not making enough blood clot, hypocoagulable states, then people are just bleeding more than they should be. And so both of these problems are pathological. The stages, first thing that happens with damage to the blood vessel, we get rapid vasoconstriction. Then the platelets, they start to adhere, they're activated, they start coming together. So I think of platelets as though they're surrounded by the soft Velcro, the part of Velcro that doesn't feel hard to our fingers. And when they get activated, they start sticking more. So this activation of the platelets, this is where we get the primary platelet plug, close up the hole. And then the coagulation proteins, all those factors with the Roman numerals, those get activated one at a time on the platelet surfaces and creating the deposition of that fibrin molecule. So fibrinogen, this is the step right before we get to fibrin. And again, fibrin's the grand finale. And that stabilizes the clot. And then once the tissue is healed, then the clot retracts. We break it up and release it, and you don't keep making more clots. That's the way this is supposed to work. Buff colored background means we're changing topics slightly. We're going to look at platelets in a little bit of detail. These are not full cells. They're cell fragments. The full cell was the megakaryocyte, so mega meaning really big. And this is the cell in the bone marrow. And then what actually leaves the bone marrow are these fragments of these cells. The production of these cell fragments is from thrombopoietin. This is the signal telling the bone marrow we need more platelets. This is coming from the liver. The lifespan is brief, shorter than red blood cells. And this is what I was saying about the surface of the platelets is like the soft Velcro stuff. These are glycoproteins that are on the surface of these fragments, and they help with the attachment of the fragments. Let's see. So platelet membrane, the glycoproteins, so carbohydrate attached to a protein on the outside of the platelets. How to think about this? The von Willebrand factor, these are proteins that are present in tissue. And when the tissue gets broken open, the endothelium of the blood vessel is damaged, and there's parts underneath that are revealed now. There's collagen and there's these von Willebrand factors. I think of those like the really hooky Velcro. And so these things would be very smoothly passing along the endothelium, but if it comes in contact with the von Willebrand factor, that's going to snag it and hold it in position. on top of that, it activates some changes in the surface of the platelets, which makes it easier for the platelets to hold on to each other and to hold on to the tissue on the inside of the cell membrane. Oh my gosh, on the inside of the blood vessel. Most of the time, the platelets are not active. They circulate in quiescent state, like smooth Velcro, the soft Velcro. Along the endothelium, the lining, the cells that line the inside of the blood vessels, those cells are producing prostacyclin and nitric oxide. So one way to remember this, nitric oxide, N for nitrogen and O for oxygen, so NO. So no, do not stick here. We do not need a clot. So prostacyclin and nitric oxide actively telling the platelets, carry on, don't change, don't get sticky, keep going. Okay, then when the vascular trauma occurs, the extracellular matrix of the tissue line inside the blood vessel, and the collagen that gets revealed, and the plasma von Willebrand factors bind, the platelets get sticky and they stick to that. Okay, then the platelets are activated. The platelets themselves are activated to secrete ADP and thromboxane A2. These are going to further activate the platelets and get more of them to bind. And so they'll be binding to fibrinogen, and this will start causing the aggregation, the collection of the platelets. So that initial platelet plug. Okay, then this is shifting gears a little bit. We're still in forming a clot, but instead of just talking about the platelets, now let's talk about these coagulation factors, the cascade of all these different proteins. So it's a system of the circulating proteins. Most of them are made by the liver. Like the platelets, they're in inactive form. So they have to be activated by the injury signals. Now I'm going to try to simplify this. They're numbered 1 through 13. They're given Roman numerals. The numbering system, let's just say it's not super helpful. But let's start. I always say the grand finale of the cascade is fibrin. This is kind of the order in which things were discovered and described. So the first one that got described was this fibrin, because that's the thing we're after with the coagulation cascade. So it gets the number 1. In the inactivated form, it's called fibrinogen. In other words, this thing is going to generate fibrin. So when it's activated, it becomes fibrin. What's the thing that activates it? I'm so glad you asked. The next protein back, and that's thrombin. So factor 2. Thrombin has an inactivated form that has to get activated to thrombin to cause this final step to happen. And you keep backing up through all the different proteins. There are 2 main pathways that they converge down to the same pathway and then culminate in the formation of fibrin. Again, the terms aren't super helpful. Extrinsic pathway, maybe the way to think about this, it's the stuff outside of the blood vessel. So this gets triggered when you break something open, and now you've revealed the collagen, you've revealed the tissue factor, the von Willebrand factor, tissue factor. Those are the things that start snagging the platelets. And then there's another part of this story called the intrinsic pathway, just to distinguish it from the extrinsic pathway. And I'll show you that on a diagram. Even though you might have tissue injury and the blood vessel gets damaged and it gets triggered, the extrinsic pathway gets triggered, it doesn't just stay extrinsic pathway. Some of these proteins start activating things on the other side, the intrinsic pathway. So I'll show you that in a moment. All right, so here's the cascade. This is our textbook's version of this cascade. So down here, even though it's not shown, fibrin is factor 1. This thing is, fibrin's factor 1, thrombin is factor 2. And then you keep going back through these Roman numerals. Don't worry about the yellow and blue for right now. What I want you to see is extrinsic pathways activated by frank trauma, meaning breaking open some blood vessels. That's on this side, the extrinsic pathway, and that activates here. And then even though we're talking about actual damage here in the extrinsic pathway, this activates here. Once you get down to thrombin, then there's this feedback that kind of pulls in the intrinsic side of things. So it's never just one of these sides. Extrinsic pathway gets things started, and then it kind of loops in the intrinsic pathway. There is an excellent Khan Academy coagulation cascade video. I've linked it in additional resources on our Canvas page. I highly recommend watching that video. The guy's really straightforward and gives you ways of remembering these different factors in order. Really, really nice. Okay, so I highly recommend that one. In our textbook, this is covered on these pages, 253 and 254. Now you've heard of the tests, the PT test and the PTT test. And so let's talk a little bit about those. The prothrombin time, the PT test, what basically that's testing is the extrinsic side of things. So tissue factor is added to anticoagulated blood. So a blood sample is taken from a patient, spun down, separate out the plasma, and then the plasma is divided. Some of the plasma is going to get tested here with the PT test. And that's testing this side of things. So tissue factor gets added, and then time it. See how long it takes for a clot to form. So it activates this extrinsic pathway, and it tests for, see if there's coagulation defects on this side of things. It also, if the patient is being treated with medication, this is the test that's needed if the patient's taking warfarin. It's usually normalized to a standard because labs will differ from lab to lab. And so that's where the INR comes from, International Normalized Ratio. So PT-INR, extrinsic pathway. The other test, so we took the plasma and we split it into 2 batches. One batch got this test, the other batch gets this test, the PTT test. And the P's and T's stand for different things than the previous P and T. So partial thromboplastin time, PTT. This is testing the intrinsic side of the pathway. Get phospholipid, phospholipid activated substances added to the anticoagulated blood. And then again, you're timing, how long does it take for a clot to form? And so this is activating this intrinsic pathway. So you're looking for problems on this side. And as we'll see in a moment, this would catch patients who have hemophilia A or hemophilia B, even hemophilia C, which we're not going to talk about too much. But this is also the test that you need to use if the patient is getting heparin, because heparin is going to impact, it's going to impact this side of things. Let me back up for a second. Notice the fibrin is the end result here, and so that's what we're looking for, and it also the end result here. So in both tests, what you're looking for is the formation of the fibrin, the formation of the clot. What's different is which side of the coagulation cascade are you testing. The 2 sides of the coagulation cascade come together here at factor 10. The little a means activated. So checks and balances in clot formation. It's this beautifully intricate system in the interest of being able to form a clot quickly, but not forming a clot accidentally. So if you get unnecessary clotting, that is clearly a sign of pathology. So there's several strategies that the body has for restraining the clotting, limiting clotting to just the location of the injury. I've already mentioned that the healthy endothelium, that is the stuff that lines the inside of all of our blood vessels, that's actively telling the platelets, move along, you're fine. Prostacyclin and nitric oxide, that no, do not clot here. So it inhibits platelet aggregation, it dilates the blood vessel, it says, nope, keep moving along. We have molecules that help lyse the clot once the tissue has healed. We have inhibitors that block the extrinsic pathway. There's proteases. How to say this? This is where that yellow and blue stuff comes in. So we have antithrombin that inactivates some of these factors. And we have protein C and protein S that inactivate some of the other factors. The point is that we have multiple systems to try to keep this in check. We want to be able to clot quickly, but we want to be able to stop clotting quickly. And I've already mentioned the intact endothelium covers the subendothelial collagen, the stuff that the platelets might snag on quickly. All right, all covered on pages 255, 257. This diagram from our book just shows that where the endothelial layer is, we get the prostacyclin and we get the NO, the nitric oxide being released, saying platelets, move it along, do not stop here. But where the endothelium is damaged, that's where you want the platelets to stick. And then resolving the clotting. Once the vascular and tissue integrity is restored, clots are broken down. We get fibrinolysis. Fibrinolysis, same thing. The plasmin breaks down. Okay, so let's see. Fibrin. We made a big deal of fibrinogen, then gets made finally into fibrin. That's the fiber. The fibers need to be cross-attached to each other. That's factor 13. It's the one that kind of ties the fibrin fibers to each other. Something called plasmin breaks down those cross links and releases the fibrin bits. Now, pharmacological modulation of clotting. If we have clotting that we don't want to have there's a number of different ways that this gets addressed. So let's separate it into acute states of clotting, like we've got a medical emergency right now, and then the chronic management of a patient who has hypercoagulable states. So there's direct clot removal from cerebral arteries, for example. Somebody's having a stroke. Then we can do the fibrinolysis to get those clots to break up fast with the tissue plasminogen activator, the TPA. We can have platelet inhibition by clopidogrel and other drugs. Integrin inhibition to reduce platelet aggregation. In the case of an acute pulmonary embolism that maybe came from a thrombus that was formed in the deep veins of the legs. This is why patients after surgery, one, we want them to walk, and two, if we know they can't walk or they're not walking as much as we'd like, we've got the little massage things on their legs, and we're giving them heparin, antithrombin accelerator. We want this to break down. We do not want clots to form. Now, if you're out of the hospital, we've got chronic management of hypercoagulable states. Patients are often prescribed aspirin. Basically, this keeps the platelets from sticking quite so much. In fact, even in acute situations, if somebody shows up with chest pain, one of the first things that they're told, or they have chest pain, chew an aspirin. It's trying to get the platelets to not aggregate with each other as much. Patients may be prescribed warfarin. This blocks the vitamin K dependent liver reactions that give rise to those coagulation factors. And there's direct oral antithrombin or anti-factor 10 agents, like, for example, Eliquis. Okay, this stuff's covered on page 258 and 257, 258. Virchow's Triad. These are the conditions that favor pathological clot formation. So we're not talking about like the good kind of clotting that you want in case of a trauma. This is the kind of, these are the factors that kind of are contributing to the formation of clots when we don't need clots to form. So the three sides of this are endothelial injury, that is damage to the inside of the blood vessels. And you may ask, well, how does that happen? Diabetes, having hyperglycemia is really damaging to the tissues, to the cells that line the blood vessels. Having hypertension, that's damaging to the cells of the inside of the blood vessels. And so that sets the stage. And you know, our diabetic and hypertensive patients have a tendency to form clots, and they suffer from heart attacks and strokes. And this is one of the reasons. Venous stasis. I think down here we have it written as circulatory stasis, same thing. Basically, the blood is not moving very quickly through an area. And thirdly, hypercoagulability, like, for example, in dehydrated states. The blood is thicker, for lack of a better word. And if you have two or more of these factors happening at the same time, it is more likely that that patient is going to form a clot. Okay, so let's see. This is applying Virchow's Triad to what we see in our patients. So large and medium-sized arteries, they're prone to endothelial injury and that hardening, the atherosclerosis that comes from, as I've mentioned, diabetes, uncontrolled diabetes, and hypertension. So we have regions of atherosclerotic plaque. Briefly, the plaque forms as the body's attempt to repair the damage. So it's not just that there's cholesterol, high cholesterol. That's not really the problem. The problem is that the endothelium is damaged, and the body's attempt to fix the damaged endothelium results in this deposition of cholesterol in the area. That's where the plaques come from. So again, having high cholesterol is not the huge problem that we used to think it is. The real problem is having high blood sugar and having high blood pressure. So the healthy endothelium that's supposed to be doing prostacyclin and nitric oxide, not doing that so much. On top of that, the plaques themselves can break. And then the inside of the clot is super sticky for the platelets. So you can get rapid thrombus formation on the plaque itself. Moving on, large veins have slow flow. So some of the veins in the legs, particularly the superficial ones are not super dangerous to get a clot in, but we'll see them forming in varicosities. But even so, the deeper ones, those are the more dangerous ones to have clots form. And so they're big veins, the blood's flowing slowly. The blood stasis promotes the thrombus formation. And that's the reason behind trying to get patients up and out of bed after surgery, up and out of bed just when they're sick. We just want them up and ambulating. So the thrombus forms there. The emergency part comes here when a bit of the thrombus breaks off, then we have an embolus. That thing, we'll go over the circulatory system next week, but basically the blood that's coming from the legs is going to go through vessels that get bigger and bigger and bigger on their way to the heart. They go back to the right side of the heart, the blood gets pumped to the lungs, and that's where this clot that came in from the leg ends up landing. because those are the first vessels that start getting smaller and smaller. And that's how the leg clots end up causing a problem in the respiratory system. So the clot breaks off, ultimately travels to the lung, creating a pulmonary embolus. And then the last point on here, atrial fibrillation. That's when the top part of the heart gets quivery. Instead of pumping functionally and actually emptying, the chamber empties each time, the atria just kind of quiver. And so they don't empty. So there's blood that kind of hangs around for a while. And I had one nurse describe this as, it's like kind of churning butter. You're churning cream, and then eventually you just get butter balls. You get clot forming. Not a great analogy, but it's one way of thinking about it. And then, so this is why our patients with atrial fibrillation are often put on anticoagulants so that they don't form clots. That's on page 259. Hypercoagulable states. I'm going to talk about two of them. This is the change in topic. That's why the change in color background. We'll talk about first genetic disorder, factor V Leiden. So mutation, there's a mutation in a gene, and it's the gene that codes for factor V, this protein right here. This mutation allows factor V to keep working as far as clot forming goes. It absolutely does its job, as part of this cascade. The trouble is, this is one of those things that's it's a cofactor. It's in blue. It's a cofactor. It's supposed to be inactivated by protein C and protein S. It doesn't respond to protein C. So where it's supposed to be getting the signal, okay, stop doing what you're doing, it's not shaped in a way that it can get that signal. And so it just keeps staying clotted. So we see a significantly increased risk of venous thromboembolism and pulmonary emboli in patients with factor V Leiden. There's another hypercoagulable state, autoimmune disorder, antiphospholipid syndrome. We'll often see it along with other autoimmune diseases, particularly with systemic lupus. This can occur, it can cause spontaneous abortions in women of reproductive age. So there are some people who miscarry repeatedly and there's no apparent explanation for it. And it may be this, the immune system is kicking on in such a way that it's actually causing clotting. Seems to be associated with the development of preeclampsia and eclampsia. And then final statement on this, if you have a patient who's having stroke or myocardial infarction and there's no other explanation for this, they don't have any other risk factors, not diabetic, not hypertensive, this raises suspicion of this syndrome. Okay, and that's covered on page 260. Now we're doing the opposite. These are the hypocoagulable states. These are bleeding disorders. We're not clotting enough. They can be platelet related. We're not making enough platelets. Thrombocytopenia is the term for that. It could be due to von Willebrand disease. This is the most common inherited bleeding disorder. So not having enough of the von Willebrand factor, it affects how well the platelets can stick. Remember, we said the platelets were like covered in like that soft Velcro, and they're supposed to catch on the hooky Velcro, including von Willebrand factor, and there's not enough of that, so it's not causing the catching of the platelets. Von Willebrand factor also interacts with factor VIII, and so the coagulation cascade is also affected. All right, now let's take a look at some diseases that are related to the coagulation cascade itself. You've all heard of hemophilias. The most common kind of hemophilia by a long shot is called hemophilia A. And then, well, it used to be called just hemophilia. And then these other versions of hemophilia were discovered. And so it was given the name hemophilia A, there's hemophilia B, there's even a less common hemophilia C. They're basically mutations in the genes that code for different factors along this cascade. So hemophilia A is a mutation in factor 8. For those of you who love this kind of detail, I put the little A here so you can see it. It affects this bit. Hemophilia B affects this bit. And again, those of you who really love detail, hemophilia C affects this bit. A and B, these factors 8 and 9, the genes for those are located on the X chromosome. So this follows X-linked inheritance. That's why we see hemophilia A and hemophilia B affecting males more than we see it affecting females. Females can still inherit this information, and if they inherit 2 copies, if they get a copy of the defective gene from their mom and a copy of the defective gene from their dad, then they can certainly have hemophilia. Males only have to inherit 1 copy of the defective gene to show the disorder. Nowadays, we identify that the patient has this. Sometimes we identify it ahead of time. And so this is managed with factor replacement. In fact, some of these patients have factor in their own refrigerators at home. So they can, if they are injured, they can provide the factors for themselves. And as an aside, okay, it's factor 11 that's affected in hemophilia C. That one occurs on a different chromosome, and so you see it equally frequently in males and females, but it's less common altogether than either hemophilia A or B. Okay, and then finally, if a patient is suffering from liver-related disease, in general, their liver is not going to be making proteins properly, including these coagulation factors. So patients that are suffering from cirrhosis or liver cancer, they're going to have trouble with clotting. They're not going to be able to clot as well because they're not going to have enough of these clotting factors in the blood. This stuff is all covered on pages 261 through 263 in our textbook. And so what do we see with bleeding disorders? There's superficial bleeding of increasing severity. We may see petechiae, purpura, ecchymoses, other excess bleeding, gingival bleeding, epistaxis, menorrhagia. And in some cases, there may be very deep bleeds, like bleeding into the joints, hemarthroses, hematomas, even intracranial bleeds. This would be more with the hemophilias. If the bleeding disorder is due to a problem with the platelets, you'll see a big decrease in the platelet number below 50,000. And if it's due to a clotting factor, you can test the clotting factors, you'll see a decrease in the number of those. And then the 2 clotting tests, the activated PTT, that's longer, and the PTINR, there's prolongation, it takes longer to form a clot. And that, again, that's covered on pages 261 to 263. Okay, finish up with pediatric considerations and then geriatric considerations. So hematological disorders in kids, fetal red blood cells have a shorter lifespan. The hemolysis contributes to neonatal jaundice. I'll see if I can say this briefly and so you can understand it quickly. When a baby is born, we go from the hemoglobin F, the fetal hemoglobin. It has a very high affinity for oxygen, and we switch over to making hemoglobin A, which still has an affinity for oxygen. The reason why the hemoglobin F Remember, through the placenta, the kid has to be able to get the oxygen from the mom. They're not sharing a blood supply, but you have to get a diffusion of the oxygen. And so having this kind of stickier in the sense of will capture the oxygen better. The fetus needs stickier hemoglobin to get the oxygen from the mom. So at birth, doesn't need that anymore, switches over to making the hemoglobin A. So there's a whole lot of red blood cells that have to be taken out of circulation and replaced. Well, poor kid's liver is not that mature, and so cannot handle that much turnover in red blood cells, which is why at birth, sometimes we'll see bilirubin, we'll see the kid turn jaundiced, especially if the kids are premature. That's why in the NICUs, there's so much of the jaundice and so much having to put the kids under ultraviolet lights to try to process some of that bilirubin, get it out, get it taken care of. Okay, genetic disorders that are often diagnosed in infancy, kids with sickle cell disease, having von Willebrand disease gets diagnosed pretty early as well. Anemia, okay, prenatal development of the red blood cells. So, oh, this is where I put that. All right. So the hypoxic uterine environment stimulates erythropoietin production. So the kid is strongly influenced to make erythropoietin, make some red blood cells in response to that. So hemoglobin hematocrit levels are quite high at birth. And then this is what I was saying before about the hemoglobin F. This is the kind of hemoglobin that's in the fetal red blood cells. And then, whew, surprise, you're born and start making the hemoglobin A. And so there's a whole lot of turnover early on. When the kid's first born, there's this big drop in red blood cell numbers. The lowest happens at about 60 days. And so that's going to cause release of erythropoietin from the kidneys, which the bone marrow is supposed to respond by making a bunch of red blood cells. Rapid growth, I think we mentioned this when we were talking about high iron deficiency anemia. In kids, in infancy, toddlerhood, and then later in adolescence, there's a high rates of iron deficiency anemia, especially during those periods of high growth. There's dietary changes in kids in adolescence and the onset of menarche for the females. Materials covered on these pages. And oh my gosh, I did go. All right, so red blood cell destruction contributing factor. Immature liver, especially in the preemies, cannot handle all that bilirubin. So there's transient hyperbilirubinemia. It's treatable. If it doesn't resolve, that could be a sign of liver disease. And why it's so dangerous, I didn't mention it here, but why this is so dangerous in infancy, where it's not so dangerous later in life to be jaundiced. In infancy, the bilirubin's being put down in the skin, and we talk about that a lot because we can see that. The thing we can't see is that it's also being deposited in the brain. And in an adult brain, it's not too bad because you're not making a lot of neurons because the neurons are stuck in the G0 level of the cell cycle. But in infancy, the neurons still need to be replicating, and that's inhibited by the presence of the bilirubin. That's how the hyperbilirubinemia of infancy can lead to permanent brain damage, and why it needs to be treated early on. All right, hemolysis due to ABO or RH incompatibility with mom. It's the RH incompatibility that's a much bigger deal. So that's what I'm going to talk about briefly. If the mom does not have a particular protein, for example, if she is type O, that means she does not have the type A or B on the outside of her red blood cells. If she is Rh negative, means she does not have the Rh protein on the outside of the red blood cells, she's going to have antibodies against those proteins. This side of things, the ABO is not as big a deal, but for whatever reason, the Rh antibodies are bad news. And so a mom who is Rh negative, but has a fetus that is Rh positive, her immune system, the production of those antibodies can be lethal for the fetus. And I'm not going to get into a lot of details about which pregnancy do you have to do the RhoGAM injection. I'm just going to leave it at this. Rh negative moms can be given an injection of something called RhoGAM. And RhoGAM inhibits the Rh antibodies such that the baby is not, the fetus and neonate is not being exposed to these anti-Rh antibodies, and hopefully will avoid all the red blood cell destruction that can happen when an Rh negative mom has an Rh positive fetus. That's what RhoGAM is about. And finally, blood disorders in older adults. We see a lot of anemia in older adults. Decreased bone marrow cell numbers. They're just not making as many cells. We talked about this actually when we were in the immune system. We said there's decreased lymphocyte activity, so that cellular immunity side of things really starts tanking as we get older. Some of the other problems that we see is hypercoagulability. The patients tend to form clots more. But then our older patients are taking a number of medications often, and that is going to impact the function of the clotting system. All right, so let's talk a little bit about the anemia. If we're talking about nutritional deficiencies, it's really the iron that's a bigger problem than the B12 or the folate. The B12 and folate may play a role, but typically it's an iron deficiency that the patient has to deal with. There are a couple of other forms of anemia, anemia of chronic inflammation or chronic disease. We mentioned that briefly before, that managing the chronic disease helps to manage the anemia. And then there's, not helpfully named anemia of unknown origin. Since we don't know what the problem is, it's really hard to fix that problem. So the mechanism is not definitively identified at present. That's why we say it's of unknown origin. And now let's talk about blood clotting in older adults. There's both kinds of problems. Some patients will have hypercoagulation problems. Other patients will have hypocoagulation problems. Let's take a look. Hypercoagulation, why does it happen? That means they're clotting more. So the healthy tissue that's supposed to be telling the platelets do not aggregate here, don't collect, some of that signaling is decreased. And so the platelets will adhere. For reasons that we're not going to talk about, von Willebrand factor gets made more. And remember, those are the kind of the hooky Velcro that can catch more of the circulating platelets. And so we're going to get, clumping of the platelets. That's going to trigger the clot formation. Okay, then the opposite side of things, the hypocoagulation. In some of our older patients, we see a decrease in the platelet number and the decrease in the platelet functionality. And as I mentioned before, there are some, many of our older patients are on a number of medications, including aspirin or NSAIDs, which also interfere with coagulation. And that is the end of part 2.